You're listening to Rehabilitative Medicine with Dr. Jonathan Whiteson on Doctor Radio.
And welcome back to the Rehab Show. You're listening to Doctor Radio and Sirius XM, Channel 110. I'm Dr. Jonathan Whiteson, one of the professors of rehabilitation medicine here at Rusk Rehabilitation, part of NYU Langone Health. And we don't just talk about rehab, we talk about blood. And we're going to be talking about blood for the next, well, at least half hour. It's my pleasure to welcome Dr. Seth Perelman. Good morning, Seth.
Good morning, John. How are you?
I'm excellent, thank you. And Sharon Sledge. Good morning, Sharon.
Good morning, Jonathan. How are you?
I'm very good. It's a pleasure to have you both on. And for our listeners, I think the most important title I can give Dr. Seth Perelman is that of geezer. And you have heard me talk about the geezers, and I will keep talking about the geezers for as long as my knees will allow me to play soccer. But Seth and I are geezer partners. We play soccer when he's bold enough to show up because I can run rings around him. That's not true. He's way faster than I am. But Dr. Seth Perelman is a cardiothoracic and transplant anesthesiologist and a clinical associate professor in the Department of Anesthesiology, Perioperative Care, and Pain Medicine here at NYU Langone Health. And he's the clinical lead for the patient blood management program here at NYU. That's what we're going to be talking about in the next half hour. And Sharon Sledge, is the patient blood management coordinator in the Bloodless Medicine and Surgery program here at NYU Langone Health. Now, I tried to say that title really quickly, and I could not. It's a lot of bloods and managements, but we are talking about management of blood. It's very interesting that we have to talk about this at this time and that there's a relationship with COVID-19. So let's start off with our current environment. And Sharon, first question, if you don't mind, to you. What is the relationship between blood transfusion, blood issues in our medical center or at medical centers around the country and COVID-19 pandemic? What is the relationship here?
Well, what we've seen happen in terms of COVID-19 and how it has affected the blood supply, really, it's been a few issues. We know that it has affected people going in to give donations. That's one way because people have been self-quarantining, as many of us have been doing that as well. Also, too, there's been a fear of people contracting diseases. People still question whether or not they can, whether COVID-19 can be transmitted via blood. I mean, we don't have any evidence to that, but those are things that are on the consumer's mind. And then we have issues of supply chain issues. So just like we see on the news all the time, there's been issues related to, are we getting enough PPEs? Respirators were in short demand, food. It's the same thing in terms of blood. And so what we found is that while many organizations, even as we ourselves have done, when we went into COVID-19 mode, we did do less surgeries, less elective surgeries. So we found that we ourselves used 40 to 50% less blood because we were doing less cases, and that's been seen throughout the country as well. So that being the case, everything appears to be fine, but as we ramp up to expand to doing medically indicated and more clinically appropriate surgical procedures, we're preparing for these issues of break in the supply chain. So then how can we still offer the care that's needed? Because unfortunately, COVID-19, although that's been the big news item, it has not prevented traumas from occurring, postpartum hemorrhages from occurring. And we know that there are other illnesses that people have that, unfortunately, blood transfusion may be a major part of their treatment.
So as you said, Sharon, even though the elective surgery rate is down, and therefore the elective blood need is down, There are other medical conditions where people are having bleeding issues or need blood transfusions. And if our supply chain isn't efficient, if there are fewer donors for because they're being told to hunker down at home, then this becomes an issue, especially as you say, as we start to need to do medically necessary procedures and operations that require or may require blood transfusions. And Sharon, blood that was donated in February, how long does that last for? How long can you keep that blood healthy for in order to give it as a transfusion, or is there an expiration date on that blood?
Well, the average lifespan on a unit of blood that's been donated is 42 days.
Yeah. So
it's very short. And in fact, that is something that organizations have seen, that less cases was done, and in instances there was blood wasted because there was no need for it. Right.
It's interesting. I see here in New York there are appeals to people to donate blood. Is that a need around the country? Are we sort of shouting out to people, if you can be a blood donor, please go and donate blood?
There's been some discussion about people giving blood, particularly with the issue of convalescent plasma that's come up.
Right.
But the American Red Cross and other blood banking centers, there are some challenges involved in that, because they too have had some staffing issues, and they too need to maintain social distancing, disinfecting in between each individual person. So it's been challenging all around. But there have been some calls, and you can even see some advertisements on televisions that they have asked people to donate.
Right. As we get back to a degree of normalcy, a controlled and healthy degree of normalcy, and we do more procedures, we're going to need more blood. There's no doubt about it. You're listening to Dr. Radio on Sirius XM Channel 110. This is the Rehab Show. We are talking about blood and blood products and patient blood management with Dr. Seth Perelman and Sharon Sledge. Of course, the lines are open. If you have a question about being a blood donor, or about receiving a blood transfusion, or about a procedure that you're going into the hospital for and you wonder whether you're going to need blood for it and how's that being managed, give us a call. The lines are open, 1-877-NYU-DOCS. That's 1-877-698-3627. You can also email us your questions, docs@SiriusXM.com. We are right here and waiting for you to call in and ask your questions. Seth, Sharon had mentioned about the fear of infection. What do we know about COVID-19? Is it in the blood? Is the virus circulating in the blood? If somebody donates blood, is there a risk of transmitting COVID-19 to somebody else who receives that blood product?
Well, that's a great question, and I think the interesting thing about COVID is that we're learning new things every day. A lot of what we assume is based on the research that was done with the original SARS and the MERS epidemics in the past. But to date, it has been found in the RNA has been found in the blood system of sick individuals, which is not surprising in a small percentage of the cases. But there has been no documented spread via that route, and it is believed that the only route of transmission is respiratory. It's also been found in the stool of patients as well, but it's believed that the primary route of transmission is respiratory.
Right.
But
you said,
it is
Seth,
a theoretical concern.
Right. You said that the RNA of the virus has been found in blood. When you say RNA, that's like a protein footprint, a genetic footprint of the virus?
Yes, the virus does not have DNA like we do. It has RNA, and when we actually do the test for it, we are looking for detection of the RNA strand.
Right.
Yes.
So that's been detected in blood, and as you said, it's been detected in stool as well. And if I'm not mistaken, I saw a study that it also has been detected in semen. So the virus really gets into every part of our body, but there's no strong evidence to date, or no evidence at all to date, I'm not quite sure how to put it, maybe you can correct that this virus can be spread in any other way other than respiratory droplet, coughing or sneezing. It cannot be transmitted, as far as we know, by transfusion.
Right, that is correct. Even if the RNA is present in the blood and it is transferred with a transfusion, we don't know about the viability of that RNA to actually cause disease.
Right. So here we are talking, about a real need. The supply chain, I wouldn't know how to fix that, but I'm sure there are great minds working on the supply chain. The numbers of donors, that's something that we need to make sure that we have people donating blood. Seth, is it safe for people to donate blood, to go to blood donation centers? I mean, have donor centers been looked at critically for infection prevention, so that we know that people who are going, who are healthy individuals, perhaps not have had COVID, and they go to the blood donor centers, are they safe to go there and give their blood?
Yes, I think we have to allay the general population's fears that the AABB, which is the Organization of Blood Bankers, has coordinated their safety efforts with the CDC and the FDA to make sure that donor sites are safe and incorporate all safety measures and social distancing. The problem is that, I don't know the times if you've donated blood. I've always donated blood at blood drives. I've never gone down to the American Red Cross or the New York Blood Center. So 80% of our blood comes through blood drives, whether it's schools or churches or clubs. And that is not available. That route of donation, which accounts for 80% of the blood, it has been shut down. So there is still opportunities, but it's a little more challenging to go down to the blood bank. But everyone should make an effort to call their blood bank and schedule an appointment. And then there is a deferral questionnaire, a health questionnaire that they would answer. And some blood banks have enhance those questions in terms of if the patient has had a recent infection or been in contact with somebody, known contact with someone with COVID, they may wait a month. And it's important to now check all these units to make sure that if someone who receives a transfusion becomes infected, to either quarantine the remaining blood or to track down the donor just in case there's any kind of connection. So there is exhaustive safety measures, but we're still always concerned about the safety of blood. It's not a drug. It's more analogous to an organ transplant.
Right. But there is a tremendous amount of screening, even before COVID-19, the safety of blood and blood products. This was, as you said, this is a biologic. This is an organ transplant, and the screening that's done for viruses and other conditions. I mean, it's really extensive to make sure that the blood products are safe, so that people who receive blood transfusions, are safe from getting that transfusion. And what about for the donor? Let's just try to reassure people who may consider being blood donors. When they go and they give a pint of blood, is there any risk or harm to the person when they're giving blood themselves, aside from COVID and our current environment? But is there any risk to donating blood?
So the healthy individual who's donating blood, no, it's a good deed. As long as they don't have any underlying conditions. If they have any severe respiratory problems or severe coronary artery disease, it's likely that they would be deferred. If they've had fever or a recent or an infection recently, it would probably be deferred. And probably on the outside of any blood center, there are these signs saying, come back another time if you've had a recent fever or respiratory infection, so they don't even enter into the system. If you give blood too often, you're, of course, at risk for anemia, but usually that is also screened. And the blood is actually tested for many infectious diseases, HIV, hepatitis. Most recently, we started testing for Zika when that was a concern, and West Nile virus, but the blood is not specifically tested. for corona. So people should not be under the assumption that, oh, I gave blood, they screened it for corona, I don't have it.
Right, understood. So Sharon, we're talking, and again, the title of your position, you're the Patient Blood Management Coordinator in the Bloodless Medicine and Surgery Program. What does that mean? What is blood conservation? What is the focus of your program?
So the focus of the program is twofold. The Bloodless Medicine and Surgery Program is being implemented for individuals for various reasons, some of which we discussed today, the overall public perception that some people are fearful of bloodborne pathogens. And then there's some people for reasons of religious reasons or morally or ethically feel that they should not have anyone's blood in their body. As Dr. Perelman mentioned, it is a liquid organ transplant. And so we tell people, as we've been stating throughout the morning, that blood is screened. There's still emergent pathogens that potentially could exist. So what we do in our program here is that we come up with strategies to conserve or save blood at every point in the patient's care. So what we've done, and over the past, I would say, 50 plus years or so, many people probably in the audience that are listening would say, well, who might that be, people who don't want blood in their care? And so many people might associate that with Jehovah's Witnesses. And they are, although I can tell you there are other people from other various faith backgrounds who feel the same way. And so over the years, the research has shown that these patients have had all type of procedures, from major cardiac procedures, orthopedic procedures, you name it, through the whole spectrum of healthcare, and they've had outcomes that's been just as good, if not better, than patients who have not accepted blood. So we know that this could be done. And in fact, this is how patient blood management was actually born. It went from bloodless, not giving any blood, to patient blood management. So actually, we may say bloodless medicine is really extreme patient blood management. And so what do we mean by that? We're basically managing the patient's blood, their own blood, in their body. So really the definition of what we might say patient blood management is, it is based in science. It's the scientific use of safe and effective medical and surgical techniques that's designed to prevent anemia and decrease bleeding in an effort to improve patient outcomes. And how we achieve that and strategize that is 4 main areas of focus. We manage anemia, whether it's preoperatively, postoperatively. We, of course, involve the patients in the decisions because we want them to have a say about how their care is managed. We optimize any coagulation problems. So if patients are having problems with bleeding, their blood's not clotting properly, we take care of that, as well as when they may be having certain surgical procedures. There's certain techniques that the doctor may use during the course of surgery, or even our anesthesiologists. Depending on the type of anesthesia they use, the patients will bleed less. We put all these things together and we individualize the care of the patient. So things like cell savers. We know that there's some bleeding associated with all surgeries. But in cases where we think patients may lose a significant amount of blood, we use a machine called a cell saver that collects the blood that normally would be thrown out or wasted, but it's collected, it's cleansed, and returned to the patient, and that's one way that we save blood. So there's various things that we do within that program, and for the patient who says they're bloodless, meaning they don't want any blood, what they mean by that is they don't want whole blood or any of the 4 major components. So that means they wouldn't take whole red blood cells, white blood cells, platelets, or plasma under any circumstances. But then we have this thing called minor fractions. Those are exactly that, minor blood fractionated products that they will take. So for one example of that is something that we call erythropoietin, which we normally make in our in our kidneys and our ribs, and that's to stimulate red blood cell production. So in our patients that may be anemic, we oftentimes use that with intravenous iron to stimulate their body, make their body into their own blood bank to try to make red blood cells at a more accelerated rate. So oftentimes we, particularly in cases that are elective, we try to correct anemia before patients go to the OR. In fact, we have quite a robust pre-op anemia program here at NYU. And for any of our clinicians on the phones that would like to avail themselves of that service for the patient, it's hashtag pre-op anemia. They put the patient's name and medical record number in, some information about their lab work, and then that service takes over and manages the patient, does all of their clearance from the insurance perspective, sets up their appointments in quite a timely manner, usually within 24 to 48 hours. We generally have them in a chair. And we can really correct anemia in many cases in about 2 weeks. So, again, as Dr. Perelman alluded to, if someone goes to the operating room in an anemic state, they're more at risk for a blood transfusion. So we try to do all we can in every avenue to conserve blood for those type of patients.
Well, you gave us a great description, and one that was really great to understand of what this program is all about. And I thank you for taking your time and explaining it in a way that really makes a lot of sense and helps us all understand how this can be done and why it needs to be done as well. Again, you're listening to Dr. Radio on Sirius XM Channel 110. This is The Rehab Show. I'm Dr. Jonathan Whiteson. My guests are Dr. Seth Perelman, who's a cardiothoracic and transplant anesthesiologist here at NYU and clinical lead for the patient blood management program, and Sharon Sledge, who's the patient blood management coordinator in the Bloodless medicine and surgery program here at NYU Langone Health. And we're talking about the need really to get blood, conserve blood, limit blood loss when people are going through surgery. COVID-19 really puts a strain on our system because of issues with donation and supply chain. And while there has been a reduced need for blood because of reduction in elective surgery, as we look to ramp up and do more surgeries, this becomes all the more important, again, that we have programs like this and recognize how they can work. Seth, are there some people who are not appropriate for this kind of blood management program?
If a person is having emergent surgery secondary to trauma, we don't have the lead time that is necessary to optimize their anemia preoperatively. So in the setting of hemorrhage, their patients may not be a candidate. In terms of cell saver, where we recycle the blood from the field, there is concern, say, with abdominal trauma, that the blood itself might be infected with abdominal contents, and in that case, we may kind of defer the usage of that. But if we're dealing with a Jehovah's Witness patients, then it's always a risk-balance ratio that we have to consider, and we would be willing to accept more risk in terms of the infectivity of the blood if it's soiled, as opposed to just letting the patient bleed out. And we do have antibiotics to treat infections, so in the setting of hemorrhage, we would use cell saver in a Jehovah's Witness patient. So those are the major limitations. And also there's some consideration, more theoretical than real, in cancer patients about blood that's lost and harvesting that and giving it back to the patient. But those are more theoretical risks.
Right. So this is more, a program that's helpful when there's elective surgery. There are increased risks when it's an emergency surgery, especially, as you said, if in the abdominal cavity as well, where there could be risk of a higher risk of infection. Are patients able to donate their own blood and get that blood back when they go through surgeries? Is that a part of patient blood management?
It is a technique that has been used. The Jehovah's Witness patients would not accept blood, even if it's their own, once it leaves their body, to return it. It was a technique that we had used in the past. However, it's fallen out of disfavor. The problem is that once the blood is removed from the body, it undergoes a what we call a storage lesion. The blood is best served being in the patient's own body. And when it comes out, there are changes in the blood. The problem we've experienced is that by patients pre-donating their blood, is that they often come to the operating room anemic. So it doesn't really help us. And you still run the risk of an administrative or what we call a clerical error. So once the blood is out of your body, it goes to the blood bank, it has to be labeled. These are all very rare circumstances, but it is possible that the wrong blood gets to the wrong patient. So it's always best to keep the blood in the patient. And instead of this, there's a technique we use called acute normal volemic hemodilution, or ANH. I use it very often in cardiac surgery. As long as the patient comes to the OR and they are not anemic, before the surgery starts, I take off their own blood, keep it on the side, and then return it after the surgery. So it's like creating your own personal blood bank on the spot, and that's a much better product than individuals who would pre-donate.
Right.
However, I will say that if a patient has a very rare blood type that the blood tank cannot secure in advance of major surgery, then it is possible for a patient to actually pre-donate his own blood, so it could be stored for this prior to a surgery.
Yeah. Seth, Sharon also mentioned there are things that an anesthesiologist can do, medications that you give or perhaps that you don't give. And I imagine there's things that a surgeon does and doesn't do in order to conserve blood. Could you just give us a sort of a few bullet points of what an anesthesiologist might do or a surgeon might do that will really try to limit the blood loss that could happen otherwise during a surgery?
Right. Well, before the patient even comes for surgery, we review their medications. There are many blood thinners that might affect either the coagulation or the platelet function that patients are often on ahead of time, and we would advise the patient not to take those prior to major surgeries. You see oftentimes advertisements for patients with atrial fibrillation on television, and they are often taking drugs that inhibit their coagulation. So we would not want a patient to come to surgery with drugs on board that would impair their ability to clot. In the operating room, managing their blood pressure, patients that have the lower limit of safe blood pressures will bleed less than patients that have extremely high blood pressure. So it's one thing that we can manage as an anesthesiologist. Intraoperatively, we will coordinate the use of cell salvage in certain cases so that whatever blood is lost, it's washed, it's concentrated and cleaned, and then re-administered to the patient. Additionally, we use certain drugs in high-risk cases that actually improve coagulation in the bleeding patient. And that class of drugs would be called antifibrinolytics.
Okay, so listen, this is just it's an area that I don't know anything about, and it's just so fascinating. And I really thank you for explaining this so clearly. We're going to be heading to the break very soon. Seth will be staying with us after the break. We're going to say thank you and goodbye to Sharon. But Sharon, these kinds, just before we go to the break, these kinds of programs, these bloodless medicine and surgery programs, is this just at NYU or is this sort of around the country? Do most medical centers have programs like this? And how can people find out more about them?
They're not in most hospitals. Actually, they're in a little over 100 hospitals, but they are growing as patient blood management is being viewed as more mainstream medicine and in many cases the standard of care. But this is actually something that's being practiced around the world, around the globe now. And so there is this movement because since we know that we could take care of patients in quite a few cases, a lot of cases, without blood, we know that if we even look at minimizing blood, we can do it with less. And so that's why even here as an organization, we've made some recommendations from our patient blood management committee for all of our patients. Is there any hospital that can truly say they're bloodless? No. All hospitals give blood, but in many instances, less is more. So we're just really trying to raise everyone's consciousness to, for every unit, just really analyze, does the patient really need this unit? Can they get 1 unit instead of 2? How are they responding to the therapy? And so we found that there's been a lot of success with that, and even things such as just even minimizing the amount of blood we take for blood tests. Why not do that for everyone? If we could do it for someone who doesn't want blood, it's good for everyone. So it's growing in popularity. In fact, the Joint Commission now has a certification for patient blood management. And so, again, it's very mainstream, and we know that it can be done quite successfully. And another benefit of it is that it does help absorb some of the financial impact that's been on the healthcare system now for many, many years. And, of course, now COVID-19 has also added to that burden.
No doubt about it. Sharon, Sledge, I want to thank you so much for your knowledge, for your expertise, for your great patient care and management, and for sort of introducing us, explaining this bloodless medicine and surgery program that we have here at NYU Langone Health. Really sets us apart from so many other medical centers. Sharon, thank you so much. And Seth, you're going to stay on the line. You're welcome, Sharon. Seth, you're going to stay with us, and we're heading to the break right now. When we come back, Dr. Perelman will be joining us again. We're going to be talking about his life as an anesthesiologist working with patients with COVID-19. Stay tuned. You're listening to Dr. Radio on SiriusXM, Channel 110.
You cut me open and I keep bleeding, keep bleeding, love. I keep bleeding, I keep bleeding, love. Keep bleeding, keep bleeding, love.
Never miss a beat of Dr. Radio with the new SiriusXM app.
Dr. Radio.
Streaming now included with most SiriusXM subscriptions. Go to SiriusXM.com/more.